Check out the full episode of the Bendy Bodies podcast on your favorite podcast app.
Something that when I first entered practice out of residency, I was very uncomfortable managing chronic pain. And so I really wanted to learn as much as I could about it. And one of the first episodes we did on the podcast was fibromyalgia with a fantastic Dr. Claw from University of Michigan.
I know him well, yes.
So he's a great guy and taught me a lot about this chronic pain. And, from there, I've just sort of tried to keep up with things. But I will say that hypermobility is something that I'm going to have to add. I'm going to have to add that to my sort of history when I'm taking a history for pain. But I do think that it's really important for anyone with chronic pain. I always tell them, listen, you've had this pain for a long time. It's going to be hard. It might take us a little while to figure out what's going to make you feel better. Is there an underlying cause that we can identify or not? And, but I'm going to work with you. I think you just have to give the patient that okay, this person's going to partner with me. They're with me for the long haul. We're going to figure this out. And I will see them frequently. Maybe it's once a month, maybe it's every 3 months, but it's not someone that I'll see once a year and just throw some meds at them and tell them they're gone. And I am usually talking about, I'm taking a full history, and, this biopsychosocial model, I think is, I don't think it's outdated. I think you can't just, I think what most physicians are trying to do is just address the biological piece of it. They're not asking anything about the patient's social history. They're not, assessing their mood and their sleep and all these other things that factor into pain. So I always try to really go in depth. Who is this person? What's gone on with them medically? What's going on with them emotionally? What's their home environment, their work environment like? And that you may have some clues there that help you out.
Yeah, no, I totally agree. I feel like with the biopsychosocial model that there are people who are very much practicing the biologic side, and there's people who are practicing the psychosocial side, but blending those together is what's really important. And the approach that I take, I have an acronym for it. It's MENS PMMS, and those letters stand for movement, education, nutrition, sleep, psychosocial, modalities, medication, supplements. So those are the 8 parts that I try to incorporate into every comprehensive treatment plan, because like you said, it's not just, here, I'm going to write you a prescription and your pain is all going to be gone. That's not how that works, unfortunately. So do you see patients with chronic pain very often?
All the time. Yeah. I mean, it's fortunately, it's not every single person I see, because I think it is, I'll be honest, it's emotionally draining for us too, to see patients with chronic pain, because the patients have that feeling of helpless. And often there's this transference of you're oh my gosh, I'm trying my best. I can't even, in some cases you can't think of things, or you're suggesting things, but they're not working. So it's hard on all parties involved. But yes, I think any physician that's practicing primary care, you're going to have patients with chronic pain in your practice. And whether it's migraine headaches or fibromyalgia or just chronic joint pains, some people have chronic back pain. Those are some of the really common ones. Like I said, I'm probably I think everybody, all my internist friends have to re-examine their panels for who might have hypermobility that we're missing in the panel. But yes, we definitely are. It's something we see and we think about.
Yeah, and the symptoms that can come along with the connective tissue disorders are so widespread. So people will come in and they'll be complaining of, fatigue or, dysautonomia type symptoms. They may or may not meet the criteria for POTS, postural orthostatic tachycardia syndrome, but, they have orthostatic intolerance. So, they get dizzy when they stand up. They've got the black shades, coming in. They're pre-syncopal, or perhaps they actually even have syncope. And GI problems. So you see a lot of, GERD, small intestinal bacterial overgrowth. You see diarrhea, constipation, food intolerances, allergic type phenomena. So if a person comes in with these complaints, I feel fatigued, I'm so tired, I have all this pain, and I have these problems with my stomach. And, so oftentimes I feel like the internist, especially if they have a shorter amount of time, they're going to be pretty overwhelmed with all of that. So I love that you're already thinking about ways to screen for this population, because you're right. It's it can be really exhausting, but at the same time, when you can work with that person and actually help them feel better and help some of these really complex cases, it's so rewarding for you and for them, because they've been sick for such a long time. So they're so happy if they can finally start to feel better. As I'm describing that type of patient that I see every day that I'm seeing patients, which I have a very small part-time, medical practice. So does that sound familiar? Are you seeing people that kind of fit that description, do you think?
Yeah, and definitely, you get a lot of patients, like irritable bowel syndrome. Of course, GERD is super common. Small intestinal bacterial overgrowth. That's actually something we're working on an episode now, like where it's a topic I feel I need to do more learning on. But I had never really, before like listening to some of your shows to kind of learn about this, I had not really made that connection with hypermobility at all. And like I told you, I was not really thinking about hypermobility for most of my patients. And it's not, for whatever reason, I don't know how many patients make the connection either. It's not like people are coming in like, hey, I'm double jointed and I have chronic pain. Do you think there's a relation to it? Like I think
no, they're not.
It's just not in the public awareness enough for people to be like coming in with those kind of complaints, which I guess like the work you're doing is helpful because now I think, you're spreading awareness of it, and it'll eventually, like, more people are going to learn about this, and hopefully you'll make more diagnoses and be able to help more people. But yeah, absolutely. I mean, there's so many times you get this constellation of symptoms and you're trying to figure out like, what could this be? You do lab testing. And I think what probably your audience knows is that if you order conventional labs thinking of only conventional diagnoses, a lot of times they're going to just come back normal. And then you're going to say, oh, well, like the workup we've done is normal, so I don't know what to tell you, you know? And I think a lot of people have probably run into that.
Yeah, they definitely have run into that. And it's true for labs, and it's also true for imaging, right? So because imaging is most of it done statically, and often it's done in a position that is not the position that exacerbates the person's problem. So they could be getting a supine MRI, for example, or some other study, and really what they need is something that shows the motion. And yeah, it's really, really fascinating because I feel like if we just changed the way that we described things rather than saying, basically, or implying your labs are normal, your imaging is normal, it must be in your head. I don't believe you, it must be in your head. But instead, if we were to say, like what you just said, for the things that we were screening for with the labs and the imaging, we didn't find anything, worrisome there. But I believe you, and I'm going to help you with your symptoms that you're struggling with. And we can always dig deeper if we need to later, but let's start working on some things that we can try or whatever. So they feel like they're being supported and not, x-rays were normal, therefore you're fine. And it's like every test has limitations. We don't tell people that.
My friend, Dr. Iris Wang, is a GI doctor, and she actually does like hypnotherapy for irritable bowel syndrome and dyspepsia and a bunch of like sort of disorders of the gut brain interaction. And she tells her patients, she says, listen, I'm going to do some testing. I think what you have is irritable bowel syndrome. I expect this testing is going to be normal, but that doesn't mean there's nothing wrong. Like, I think so she kind of says like, the testing being normal tells me that I think I know what's going on with you and I know how to treat it. So I think that is like you're saying, we need to reframe things. And that's, I think, what's really frustrating for a lot of patients is because there's, and I think we've learned about this in the past 5 years, at least I have, where a lot of people are trained in medical school. You're basically told like, follow the party line, what these big organizations, if it's in an expert guideline, then that's, you got to follow that. Don't think for yourself. And I think people are starting to more think for themselves and just say, well, wait a minute, these big organizations, they get things wrong sometimes. And the scientific method is such that like you need to constantly say like, oh, there's new information. I can change my thinking based on this new information that I've learned. And I think medicine in general needs to get a lot more humility and start to like accept that, and not, that shouldn't be controversial to say that. But I feel like, you know, I don't want to get into talking any politics about anything, but I just think that if you ask me like what has changed most about how I think about the world and my profession in the past like 5 years, it would be just sort of like investigating things for myself. We do a journal club on Curbsiders where like just because that new drug got approved and they had positive results, I'm very skeptical like whether or not I'm actually going to prescribe it for my patient, because I know it is very easy to make a trial a positive trial, and do we care about the endpoints that they pointed to? And so, that's where I'm at, and that's why I like, as a person and as a physician, I like to constantly learn more, constantly evolve, and don't hold on too dearly to any of my current beliefs because they might change.
Yeah, I think that's such a great attitude to have. And there's no FDA approved treatments for hypermobile EDS. So if we were to just go strictly off of that, we would not prescribe anything.
Right. Which would be an insane way to go.
Correct. It would be ridiculous because in the meantime, people are suffering, and there are things that we can use that we can extrapolate from other conditions. And I just think, yes, it's important to read the double-blind randomized controlled trials and be looking at the evidence, but it doesn't all have to come in that form of a big study. And like you said too, things can get approved that are not necessarily the best idea. Mm-hmm. And sometimes I say, you know what, let's wait a little while and see if things, as they're prescribed to more people, there's much larger numbers, even though, obviously they went through phase 1, phase 2, phase 3, but now let's see, as it gets applied to more people, are there other things that are going to come up that maybe are side effects that we would really, really want to avoid? So yeah, I think those are really good points.
And part of the thing that we need to realize too is like, there's just certain, if it doesn't make sense for a trial to be done financially, if there's not like, then a lot of the times the trial is not going to be done, or it's too expensive, and mm-hmm. and it's not going to pay dividends down the line, so they won't do it, even if it would ultimately give us good information and help benefit patients. sometimes you just have to like practice based on a hunch. And, of course, you're trying not to harm the patient, and you're letting them know, here's in theory why this may or may not work. Here's what we know. Here's what we don't know, the risks, the benefits. But that's kind of how you have to practice. And if there's no real strong trial to guide like what you're doing, you just have to, that's the best that you can do. And you're essentially running an experiment on the patient with their consent and trying something. And then you're reassessing. And I think that's the way to go.
Check out the full Bendy Bodies podcast episode on your favorite podcast app.